In this episode, U Lethbridge Therapeutic Recreation Professor Dr. Sieanna Caspar examines knowledge translation and mobilization in healthcare. The move away from task-oriented care toward person-centered care is considered by many to be essential to both the quality of care and the quality of life of people residing in long-term residential care homes. In this talk, Dr. Caspar shares 4 key findings from over a decade of research that help us to understand the factors that support practice and culture change initiatives of person-centered care.
I want to give you a little bit more background about me. That was my introduction, but in addition to working in long-term care for over 20 years as a recreation therapist, and then also being a consultant and going into care homes, I have also researched long-term care and quality of life and quality of care, and I was also a family caregiver. So I've had family members who have lived with dementia, and also family members. Now my mother actually has just recently been admitted into a long-term care home. And so these topics that I'm talking about are quite personal to me. It's more than just a professional motivation for me. It's also a personal motivation for me to research this. And if you have a personal motivation, you have to have a burning question. And my burning question, which was cultivated over my years of work in long-term care and then researching it, is why is person-centered care so hard to implement? Because we've known for like well over a decade, we're talking close to 2 decades, that this is what we should be doing, this is what we want to be doing, and yet, despite significant effort to alter practice, despite significant commitment to actually realize this goal of providing person-centered care consistently, we continue to struggle in healthcare settings. And so that's my burning question, and I want to talk about what I have learned in my career as an academic, and then also in my own personal experiences as well, about why it's so hard, but also how to make it realized. And if we're going to talk about this, I think it's also important, though, for me to start with defining what do I mean when I'm saying person-centered care. And one of my favorite definitions comes from Fazio, and person-centered care is a care philosophy that respects the care recipient's preferences and life history, honors identity, enables engagement in meaningful activity, and encourages an overall sense of well-being. So if you hear that, you're like, well, but of course, this is what every care recipient would want. They want to be known as a person. They don't want to be a room number. They want to be actually honored in their wishes, and to have care that is provided that actually recognizes that and values it. We also know that one of the reasons this is so important is that this type of care is essential to the quality of life and quality of care of individuals who live in long-term residential care homes, especially those with Alzheimer's disease or related dementia. We know that, it's widely recognized and widely accepted. Despite that, though, we continue to struggle in our efforts to provide it consistently. So I'm going to try to actually summarize like 4 key findings that I've found in well over a decade of research in my journey towards trying to answer that question of why it's so hard to actually implement. So the first key finding is that educational interventions are largely ineffective in producing changes to care practice. And this finding began from a systematic review that I conducted of 87 intervention studies in long-term care. And I really focused on the correlation between the intervention factors and the effectiveness of the intervention. So to categorize those intervention factors, I categorize them based on a model by Green and Kucher, and I categorize them into predisposing factors. So this is the dissemination of information. This is your education. This is your in-services. And this is what we typically want to go to and think that if we simply educate people, well, then we'll make change. The next, though, are enabling factors. And these are the conditions and resources developed to enable the implementation of the new information that you received in the education session. So these include things like modifying work environments and schedules, giving practice opportunities, making changes to policies and treatment guidelines, and having access to the appropriate resources. And then finally, the third factors that I categorized these intervention factors into is called reinforcing factors. So these are the mechanisms that reinforce the implementation of the new knowledge or skills that we've gained. So these include things like cues and reminders and improved peer support. And I would also say peer pressure. Peer pressure has a lot of influence on what we do, when we do, how we do it, and why we do it. In addition to timely and appropriate feedback and consistent follow-up and rewards and recognition. So when you look at interventions aimed in healthcare to try to improve or change the type and quality of care and implement person-centered care, what I found is that the majority of studies did not include any enabling factors. They used only predisposing factors. So unfortunately, what happens there is that not only do they not work because they're largely ineffective, when you teach or you give education to care staff, a care team, about how to improve the quality of care that they want or could or should give, and yet you do not enable them to take that knowledge and actually apply it in their day-to-day work life, not only do you not produce change, but you increase moral distress for these care teams. And yet that's what we keep on doing. I can't tell you how many times I sat in in-services when I worked in long-term care, and we bring in the whole care team, and you'd learn about best practices and what we should be doing and could be doing, and everyone would go like, yes, I want to do this. And then they'd go out onto the floor, but they didn't have anything put in place to enable them to actually change their care practices. And when you think about this, these studies that I was looking at, these are research studies. That means they come with research dollars. That means they come with additional supports to actually implement this. And yet, the majority only used education and didn't actually look at how do we help them actually implement this, so enabling factors. The other thing that I found is that the presence of reinforcing factors, and that's that peer support, rewards recognition, appreciation, those types of things, were actually the most significant predictor of whether or not that intervention was going to result in changes in care practice. But I can't tell you how often we have this assumption that, well, if we've taught you to do this, then it's your job and you should simply do it, and we shouldn't have to reward or recognize you for actually making changes in your care practice. Well, that's crazy talk. Because if you think about you, if you've wanted to make a change in your own personal health and wellness behavior, if you've got no rewards or recognition or atta-go girl or what, the likelihood of you actually making those changes and sustaining them is very, very, very low. So these are the things that we need to think about, because what I found is that unless effective, feasible, and sustainable enabling, reinforcing factors are included to any education in trying to change care practices, the day-to-day practices and routines, which places typically more emphasis on regulatory compliance than on individualized resident care needs, that's just a reality, will likely be in direct conflict with the successful implementation of any intervention in trying to produce changes in care practice. So that's the first finding. The second key finding is the quality of workplace relationships has a direct and meaningful influence on care aides' ability to provide person-centered care. This is a structural equation model. You do not have to be able to read this. I'm going to tell you exactly what this says, and the actual numbers do not matter. This was from my master's thesis, and what I did is I went into over just 64 different long-term care homes across 3 different health authorities, and I gathered data from just under 700 care staff, RNs, LPNs, and care aides. And what I was wanting to explore was this relationship between, my hypothesis was that the more empowered they were, the more able they would feel to provide individualized or person-centered care. And not at all surprisingly, my results were yeah. And that was kind of like I was just shocked that that question had never actually been asked and hadn't been answered statistically. That was not a surprise. What was a surprise is this red box here, and I know you can't read it, but what that is that box told me that for care aides, the quality of their workplace relationships had a direct impact on their ability to provide person-centered care. More so than resources, more so than education, more so than formal power, more so than anything else. And I was not anticipating that. And those of us who are in research, like when we come up with a result that surprises us, that's yummy. That's like, okay, I want to unpack that more. Why is it that the quality of workplace relationships has a direct impact for specifically care aides, who are the individuals who provide the vast majority of the direct care in long-term care homes, to their ability to provide person-centered care? And I knew I wouldn't be able to unpack this and understand it with more statistics. So I learned an entire new way of conducting research. I learned qualitative research methods for my PhD, and I did what's called an institutional ethnography study. I used that as my method of inquiry. And I actually went into long-term care homes and I shadowed care aides for the full extent of their care days, their work days, evenings, and nights. And though I was shadowing the care aides, they were not what was under investigation. What I was investigating was the organizational systems within which they work and how that organizational system enabled or impeded, in other words, supported or hurt or hindered their ability to provide person-centered care. So I was watching them, but more importantly, I was observing how the system impacted what they did, how they did it, why they did it, and when they did it. And what I found was, well, I found out so much. I learned volumes. If you think you understand, like that, shadowing someone in their workday, it's still not walking in their shoes, but at least it's walking by them the whole day and to learn from them, the experts in person-centered care. And one of the things that I really wanted to understand is, if you remember, my definition of person-centered care is care that honors the care recipient's identity, their histories, their personal preferences. And I thought, if you want to provide this type of care, we got to understand how care aides find out that information about the care recipients. How do they learn what these people like and what they need and what their personal histories are? And I found that for care aides, they need to learn this information orally. But the medical system really wants them to read everything. We want everything written down. That adage, if it's not written down, it doesn't exist. We believe that firmly. And with all of the advent of the computerized medical record, and we are actually removing our care teams from being able to talk with one another, being able to connect with one another and learn with one another. And this is a negative impact on person-centered care. It may make some things much more efficient, but if we're really wanting care teams and care staff to know the residents that they are providing care to and to know and work with each other as a team, they have to be able to communicate with one another. Because what I learned was that care aides, they receive this information orally. Now, there's a lot of reasons for that. One of them is, by and large, most of the care aides are women who are immigrants, and English is a second language. So coming together and being able to ask questions of one another and being able to understand and learn from one another orally, in other words, when they're speaking rather than reading a chart, is really essential to this group of people. But also, those charts don't always ask the most important information to the care aide. So here's an example of one of a beautiful exemplars of person-centered care that I observed. There was a resident who had recently had a stroke, and the care aides had figured out that if she was seated at the dining table facing her table mates, she would refuse to feed herself. And this is because the stroke had impacted half of her mouth. And she would as she was feeding herself, the porridge would drip down. And so she refused to eat. But the care aides, in their amazing, creative, open, and connecting way, had figured out that if you face this resident towards the window, then she will feed herself, and she will be happy to then engage socially with the other residents once she has finished eating. There is nowhere for this information to be placed on the medical record, but this had to be communicated because as soon as one care aide learns this, everyone needs to know this. Because otherwise, what happens? The resident gets seated at the table when one person who knows it, and then she stops eating, and everyone just assumes. And then what do? Is they just start feeding her. So this person has now lost this functional skill. Because now she's being fed. So that's just one example. And the only way that type of information, which is so essential to person-centered care, gets shared between the care team is if they can come together and talk. And the other thing is that whether or not they come together and talk, though, is absolutely dependent upon the quality of their workplace relationships. If they don't like each other, they don't talk with each other. And here's a quote from one of the care aides. She says, if two girls don't like one another, one great tip that one had that could save us all time and injury doesn't get shared. So one care aide figures out how to actually give a bath to Mrs. Smith, who has advanced dementia and is very resistant to this care routine. And she figures out exactly how to have this actually be a positive experience. That tip only gets shared so long as that care team get along with each other. Otherwise, it doesn't. So remember that statistic that I showed you? Well, that's one of the reasons why the quality of workplace relationships is so essential for the provision of person-centered care. Key finding number 3, and I've been told I have like this hard, fast, so if I'm going really fast, I'm sorry, because I, of course, probably put too much into this presentation, but key finding number 3, the presence of leaders who demonstrate respect, show appreciation, and give recognition, and actively respond to the needs and concerns of staff is essential to any initiative aimed at producing changes in care practice. I have found this repeated over and over and over again. The quality of leadership absolutely is foundational for the provision of person-centered care. There is no way any of you are going to be able to read that, and nor can I. But I can describe it because I know this model really, really well. This finding is actually summarized in this pyramid. And on the bottom of this pyramid is empowered leaders, empowered team members. And empowered leaders and team members consistently engage in 3 behaviors: respect, recognition, and responsiveness. These team members and administrators and managers consistently let the care team members know that their opinions matter and the work that they do matters. That's that respect. Recognition is they catch them doing a great job. You don't only see managers out on the floor when there's a problem. You see them out on the floor catching care teams doing great work all the time and thanking them for it. And then responsiveness is they're actually willing to ask the care team, what do you need from me to help you do a great job? They're willing to ask that because they're willing to hear the answer and they're willing to do the work of making adjustments to help them do that. This is actually, I can summarize this model by just saying that key phrase was one of the things that I found that differentiated a long-term care home where you saw a lot of person-centered care versus one where you didn't. And when you had a manager who was out on the floor and asking the director of care, what do you need from me to help you do a great job? And listening and responding to the needs that that director of care said, then that director of care would go to the RNs and say, what do you need from me to help you do a great job? And the RNs, because their needs were being addressed and answered and responded to, they would go to the LPNs, the licensed practical nurses, and they would say, what do you need from me to help you do a great job? And because they were being asked that and answered that, the care aides, the LPNs would be able to go to the care aides and say, what do you need from me to help you do a great job? And because the care aides had someone asking them that question, they were able to go to the residents and say, what do you need from me to help you have a great day? What do you need from me in order to make this bath experience be a positive one? The alternative is when you have managers who feel so much external pressure, so much, external pressure to meet compliance and meet standards and have all of these boxes ticked off, that what they do is they go to the director of care and they say, I need from you this, and this so that I can get my job done. You need to make sure that all the baths are being done at this time and that these weights are being done. And so then that director of care goes to the nurses and says, I need you to do this, and this to help me do my job. And then the nurses go to the LPNs and they're like, okay, your RI MDS isn't done on time. I need that done on time. And I need all these weights done on time. I need all of this done. I need this from you to help me do my job. And so then what happens is the LPNs say that to the care aides, you haven't filled out your flow sheets because I need your flow sheets filled out so I can do my RI, and I need this from you to help me do my job. And what do the care aides do to the residents? I need you to eat right now. I need you to be up. I need you to be through this bath. I need all this. This is what I need from you to help me do my job. It sounds simple, and it's kind of because it is, and it's that powerful on whether or not one person is asking and really listening to the answer, what do you need from me to help you do your job? And if that trickles down, that's a powerful, powerful predictor of whether or not person-centered care can be offered. This pyramid, kind of everything I just said can be summarized into that. I can say that when that is present, what you have is you have organizational trust. And when you have organizational trust, you have reciprocity within the teams. And teams come together and they know that they're not just caring for residents, they're caring for each other. And when you hear in a care home, we are a family here, that's an outstanding care home. And those stories that we heard, I'll get all choked up, those stories that we heard during COVID, the horrific ones of residents being left and literally staff just walking away from residents left in feces, I can tell you right now, none of those care staff ever got asked that. They never got asked, what do you need from me? Those were care team members that never felt like they were also being cared for. I just believe that emphatically with all the work I've done in long-term care homes. Sadly, they made the news every single time, and we needed them to make the news. But what didn't make the news were the care aides and the RNs and the LPNs who actually moved into the care homes during the pandemic so that they could safely care for the residents. In those care homes, absolutely, they were a family, and there was a culture of care there, and they knew those residents as people, absolutely. So this model just really says that the foundation is managers who really know their staff, care about them as people, and respond to their needs. And if you can imagine, of course, then you've got staff who know their residents and can respond to their needs. Key finding number 4. When you galvanize a care team by empowering them through the cultivation of leadership, teamwork, and collaborative decision-making, they can accomplish just about anything. And I've had the privilege of being able to work with some care teams that they blew my mind, and I've got a colleague in here who was part of one of those studies. This whole started with, I was tasked by the Alzheimer Society of Canada. The head of research came to me and she said, Sieanna, we want to try to change meal times and make them more person-centered care, more person-centered in long-term care homes. And we've chosen meal times because they're concrete, they happen every single day, and they have this amazing ability to potentially really impact quality of life. for residents. And yet, they're also an area that are really in need of improvement. So we want you to try to take this on. And I was like, all righty. Absolutely, let's try this. And so I went into, we got assigned a unit that had 12 residents to do this study to try to really change the culture of care on this. And this was a challenging unit, though, because in this particular care home, the care teams, it was on a floor that had 4 units on one floor, and they rotated every 3 to 4 shifts. So that means that when you're working with one group and you're trying to get them on board, you got 3 to 4 days, and then they're gone for about a month. And you got a new group, and you're trying to get everyone on board. Not an easy way to try to actually get change and have it be consistent. There was also the position that was supposed to be the leader, like the director of care of that unit, or that floor. That person resigned the week that we were doing participant recruitment. And that position wasn't filled through the duration of this study. So we didn't have a person, our go-to, who should have been able to keep us connected to each of these teams as they were moving. So this was not your typical healthcare environment where someone wants to try to do an intervention study. Let me just put it that way. But I thought, but this is typical long-term care. So if we can make change here, we can make change anywhere. So let's do it. Let's roll up our sleeves. Let's do it. And this is what we did. And I'm going to read this to you because I know you can't see it. When we started, and we did measurements, but all of these changes that are on this graph, they happened within 3 weeks of us doing this intervention, and they were maintained for 6 months while we collected the data, or were collecting data. So when we first started, actually I'll go this way because then I'm facing the mic. So when we first started, residents were told where to sit. They weren't given a choice 100% of the time. Within 3 weeks, that only occurred 10% of the time, so they were given some choice. Clothing protectors were put on residents without asking them, without letting them know. 100% of the time, that dropped down to 20% of the time. Residents are asked what their meal or beverage preferences were, only 10% of the time. That means that when you were admitted, if your family member told the care team that you liked apple juice, that's what you were getting. There were no choices. You could not change your mind and decide that maybe on this day you might want cranberry juice or orange juice. No. So you didn't have a choice of either your meal or your beverage preference. That changed 100% of the time. Residents now had a choice. Medications, this was one that we weren't able to move that much. I don't know why people haven't figured out that if you really want to ruin a mealtime for someone, just crush their meds and give it to them right in the middle of their meal. And we think applesauce might, mask that flavor. No, I mean, that's that's a guaranteed way to not have a good meal. And yet that's what we do because this system is built that way. We worked really hard to try to change that. We didn't get that one moved that far in this particular study. We replicated this, though, little shout out. We replicated this exact study in another facility organized and run by another long-term care organization, and they absolutely stopped that practice within 3 weeks and maintained that. So no longer were crushed meds being administered or given to residents in the middle of their meal. Residents were included in staff conversation less than 60% of the time, residents were excluded from staff conversation. This means that residents who are being assisted with eating by staff are talking to each other and not actually including the resident during the meal. That was happening 60% of the time. That dropped down to only 20% of the time. And the next two I am so proud of. We got staff to sit down with the residents when they were feeding them or during the mealtime. That happened 0 when we started, and it was increased to 70% of the time. That may seem trivial, but that's a huge thing, because what we know, especially for individuals who have dementia, if you sit down with them, they recognize that this is a mealtime and they engage in socialization, and it increases their nutritional intake. Also, you develop relationships between staff and residents then, because they actually talk with one another about something other than care or care routines. And then finally, residents were able to help with setting the table and clearing the table. 0, never, when we first started, and that increased to 100% of the time after this study. So what this did is this cued the residents that there was going to be a mealtime. This was this unit that we were on was a locked unit. It was a secured unit. It was for individuals with advanced stages of dementia. And they often don't sit down to eat. They like to sit down is like this thing that it'd have to be really socially cued to do that. But because the staff were sitting down and they set the table, it cued them cognitively that this is a mealtime. And then they sat down and they ate. So it was amazing, our outcomes. I was blown away. And I cannot take responsibility for this. All I did was come in with a model that helped to empower the team who would know what could be done, how to do it, and how best to implement it to make sure it was sustainable to be successful. We replicated that and had the same exact outcomes, in fact, even better, in another study in another long-term care home. And then because it was replicated, I thought, I've got something here. I've got something that I need to actually formalize, and so I did, and I called it the FASI model, the Feasible and Sustainable Culture Change Intervention. These are the things that are included in it. I don't think that really matters, but what you need to know is that all of this is accessible to anyone who wants to access it and use it to help change care in their care homes. Moving right along, I then had the opportunity to work with, like, one of my favorite studies I've ever done, Dr. Shannon Spenceley, who decided to take on the really tough topic of mitigating or decreasing moral distress in continuing care. And moral distress occurs when care staff know what they want to do, they know the quality of care they want to go, they know what they should do, and they can't. They can't give person-centered care, and they know they want to. And we went in, we did a version of a random control trial. We had 2 intervention, 2 control sites. We used measures at 1, 2, and 3 months after the intervention. And what we found blew our minds. We found that moral distress was reduced 20 to 25% at each measurement point. In other words, after 1 month, we reduced it from 20 to 25%, and then at 2 months, we reduced it another 20 to 25%, and at 3 months, another 20 to 25%. And these were some of the key ones that mattered to me. There was a reduction in the frequency of having to rush care of residents with dementia, even though I know it might upset them, 20 to 25%, another and another. A reduction in the reported intensity of moral distress related to situations related to poor communication, a lack of knowledge and skill, and in the frequency of feeling sad, guilty, physically sick, like a failure, or like they wished to call in sick or wanted to withdraw from residents with dementia. So if you can reduce these things, you are absolutely, and you know it, increasing quality of care. We also found in our focus groups the consistent improvement in desired outcomes. In other words, they selected what they wanted to change and they made it happen consistently. These teams were so empowered, nothing was going to hold them back. Shannon's here nodding, yep. The other thing that was amazing is that these teams were actually pulling the change. So we would just go into one unit in a care home, and what we found is that other units were finding out what this unit was doing, and they wanted some of that. And change is stressful. Change in healthcare teams, well, a lot of people will tell you it's impossible. But not only did it happen, but people were pulling the change into other units. They were pulling it into other parts of their facility. That's amazing. But it mainly, though, again, it's not us. It's empowering these teams. It's looking at them as the experts, and it's helping get rid of the roadblocks that stop them from being able to literally, to quote a brilliant man, be the change they want to see. So these findings, they were pretty exciting for me. But even if you've got something that you know works, it doesn't matter if no one else knows about it. And so I turned my attention to how do we get this information out? And that's knowledge translation and knowledge mobilization. And I thought to give you the definition from Shirk what knowledge translation is. It's the reciprocal and complementary flow and uptake of research knowledge between researchers, knowledge brokers, and knowledge users, both within and beyond academia, in such a way that it may benefit users and create positive impacts within Canada. So to me, coming up with a model, getting it published, really doesn't matter unless people are using it and have access to it. So I spent a lot of time, a lot of energy, and a lot of resources developing what is called the Relational Care Knowledge Hub. And this entire FASE model, all of the training, all of the education, the manuals, users' guides, everything is available for free for anyone to be able to access. And I can just show you it, if this magically does come up. There it is. So this is the website. It's all designed, and I want to have a shout out right now. This would not have been possible without my friend and colleague, Dr. Julia Brazilato, not deciding to back me and back this and say, I believe in this, and I think that I want to support it. And she assisted me with some of her Alberta Innovates New Investigator Award, and also the Brenda Stratford Foundation. They actually created process improvement team leaders as positions, so that they have people whose their job is to actually implement the FASE model and help produce change as a result of that. So just to, oh, and I also have to say, and she's here, Caitlin, Caitlin Scott, I had the ability, and I'm so fortunate to be able to hire her as my project coordinator, and none of this would have happened without having someone as awesome as her to assist me, and when I said, we need this, and she was like, okay, consider it done. And any of you who've ever had someone who you could say that to, you know how valuable that person is. So this is what the training series looks like when you go in to it. I went into an actual recording studio. Each of the, oh, you can't hear it, which is fine. Oh. It's a nice little song. We're not going to watch this for very long because I hate.
We'd like to take this opportunity to offer you a special welcome.
Okay.
As the
So just so that you know, that's what they look like. I hate seeing myself. This is hard enough. But in there, there's a welcome handout. We have an entire process improvement team coordinator binder. All of it is available for free to download and to use. We have outcome measures to help people know whether or not what they're doing is working, built into this. It took a lot of time, and it's available to anyone. And I'm quite proud of it. It has been used and accessed from 4 or 5 different countries already, and people are turning to it, and that's fabulous. And I think that's it. That's how much I was just like really. We can go back to the because I know I'm watching the time. So I want to though talk about if you can. I don't know. You might be able to imagine how much time went into the development of that. Like every single font had to be selected. All the documents created. All of that. It was labor intensive. And I want to talk about one of the other things that I have learned, though, about this. I had to make a real choice within my career to spend 2 years putting that together. And it was a choice that wasn't easy, and I think it should have been easy. Because if this is a model that can actually improve the provision of person-centered care, then it needs to be, like, we as academics need to feel confident in investing in ways of getting this information out beyond our published research articles. So I published on this, but that is not going to produce change in the long-term care home down the street when you publish in an academic journal. And so I want to talk about some of the things that I have found in my stage of my career, because I have the privilege of saying it's okay that I'm not going to increase my H-index, which is like my number of citations and everything at this point in my career. I just honestly do not care about that. What I really care about is I think I've got something here that could be helpful, and I want to get that information out. But how and what is valued by the Academy absolutely was on my mind when I was making this conscious decision. And the value is, the definition of value is the importance, worth, or usefulness of something. And I started having to ask myself, actually fairly early on in my academic career, is does the Academy truly value knowledge translation? Does it truly value it? Now we have to, in any of the big grants, we have to write up how we're going to do knowledge translation and knowledge mobilization. Yes, we do have to do that now, but we still have a long way to go before I can strongly and clearly say, yes, the Academy values knowledge translation and mobilization. And here's why. I told you I used institutional ethnography as my method of inquiry for my PhD. In an institutional ethnography, we begin with the exploration of lived experiences of people directly involved in an institutional setting. So in this case, this is me, the researcher, the academic in the institution of the University of Lethbridge. But the purpose is not to generalize about people, it's to discover and describe the social processes that shape our activities. And how we uncover social processes is really looking at institutional texts. So institutional text is any document that can be replicated. And in institutional ethnography, we say that these texts are the visual representation of the social processes that we're trying to understand. Now, I know that's a whole bunch of big words, but what it means is our documents drive what we do. They really do. So there are two key institutional texts that I want to focus on from the Academy. And the first is what's called our curriculum vitae. That's our CV. And our CV is like a really, really, really long resume. Our CV is like, it's supposed to be an exhaustive list. In other words, it is everything, an exhaustive list of all the significant achievements in our careers. This includes our education, research, work, experience, publications, presentations, and anything else we've done in our professional life. This is supposed to be a complete account of the work that we do and what makes us justify our claim as an expert in our field. So I took part. I didn't realize what a privilege it was to be invited to this group of kind of elite researchers in healthcare who focus on implementation science. And I was invited to this group, and I asked them, where do we put this on our CV? And none of them had an answer to this question. And I said, do you know how big of a deal it is that we don't know where it's clear to put knowledge translation and the work that we're doing on knowledge mobilization on our CV? And I said, like, this is serious. And so one of them took me up, and we did a study. And we interviewed, or we surveyed 153 health researchers internationally, and less than half intended to report any knowledge translation. And and on their CVs, and only 33% intended to report the impact of their research on their CV. This is health researchers, and they're not going to report knowledge translation. That's interesting, internationally. And when we asked, their main barriers were CV templates that did not include research translation and impact activities. So you have a template, and there's no place to put this in. They also said they perceived employers did not value research translation and impact activities. And finally, there were a lack of metrics to evaluate research translation and impact. So if there's no place to put this on your CV, is it truly valued? When we're saying the CV is everything that we do? 96% of the people who we interviewed, these are health researchers from around the world, were unaware of a CV template formatted to include research translation and impact of reporting. From an institutional ethnographer's perspective, we would say this is a problem. The other is here in the University of Lethbridge is called our professional activities report. So this is bringing it a little bit more closer to home. That was international. And this is it's called our PAR. And this is one of the most influential institutional texts that you can find in our institution, to be honest, if you are an academic, if you're a professor. This influences our extension of probation, in other words, whether or not we can keep our job after we're hired. It also influences our tenure, whether or not we get tenured. It influences whether or not we get promoted from assistant to associate professor. And it also influences our salary. And on our current PAR form, knowledge translation and mobilization is not listed. Again, it's not on the template. So for me as a researcher, when I am deciding, am I going to spend the time getting 3 manuscripts published, which we still have to write, or am I instead going to spend the time creating a website that there is no place for me to actually list? But it could make a difference. And I opted to create this. But it actually could negatively impact my career trajectory. That's a reality because there's not the metrics. So this is, you can't read it, but this is for research and creative activity on our PAR form. There's publications, there's manuscripts submitted for publications, there's paper presentations and participation in professional meetings, there's creative work and even performances. So it's not that it's not inclusive. There's editorial refereeing, examination. So it's not that it's like vague, but what you'll see here, there's also research and creative activity in progress. Now, could we list knowledge translation there? Yeah, we could, kind of, if we're going to call that a separate research study, though. I didn't know where to put this on my PAR. I've also just spent time creating another website with tons of resources and a very labor-intensive, again, in trying to get information out to the public in the Center of Excellence for Therapeutic Recreation. I don't know where to put this in my PAR. So in a sense, I'm doing work that I know may not officially count in my career. That's problematic. So now we come full circle. Because what happens is that whether or not we recognize it as influencing our decisions in the work that we do and where we decide to focus ourselves as academics, it absolutely is. When you don't see it listed, I have a table of students here. It's like, if you don't see it on the test, you know, how important is this, right? If it's not on the assessment in the care home, how important is this information? It comes back to then full circle. If we in the academy don't truly value this work, we are in effect discouraging academics from doing anything more than staying with predisposing factors. Remember the very beginning? Education alone doesn't work to produce change. And that's a problem. But now I want to talk about really quickly the industry as well. Because I've also learned that there's a catch-22 when you offer resources that are free. They're not valued as much. So here's a problem. I have all of this. I produce all of this. It's free. But because it's free, it's really actually hard for teams to be able to take it up because the administrators don't have to have an investment in it. I actually built into one of my studies knowledge translation, and so I had funds to travel to educate people on what I had learned. And we had so many people interested in this that I had to have 4 different days in 3 different cities. We had wait lists. People, couldn't make it in, and I had funds to provide food because it was a full day training. And we had to add an extra day in Edmonton, so I had to go up there twice for this training, and it was free because I wanted it to be free because the long-term care industry is not a resource-rich industry. They will tell you we don't have the funds to spend on doing this, so I was like, all right, I'll make it free. 40% of the people who signed up, and these people signed up and they asked for like vegan meals with no dairy and other like gluten-free meals. 40% of the people who signed up didn't show up. It was free. And I realized they didn't value it as much. So coming back to values, I realized I needed to charge for that because then they might have valued it enough to at least show up, right? And so that's a problem. So I've got this. So again, because it's free, I actually have to put more energy into getting the information out there and getting buy-in from administrators because it's free. But that extra time that I'm spending and going around and presenting, I can't list that I've presented on this 10 times on my CV. That actually is kind of frowned upon. But in knowledge translation, you have to. So there's this catch-22, and it's an interesting one, and it's a problem. Leadership has to be invested in it, and sometimes they have to be invested by their dollars in order to actually help and ensure that it gets taken up and gets paid attention to. Now, that's kind of depressing, and I always want to end on a positive note. Really, the answer to this question of what enables person-centered care, so much of it does just come back to what we value. And I love this quote by Brené Brown. I define connection as the energy that exists between people when they feel seen, heard, and valued, when they can give and receive without judgment, and when they derive sustenance and strength from the relationship. That's what it's all about, having people feel seen, heard, and valued. And what I want to say right now is thank you for being here, for helping me to feel seen, heard, and valued, because you showed up on a really wintry night. And you came to listen about a topic that is really about how we care for our most frail population, our elderly. And obviously you care about this, and that matters to me too. So thank you. Thank you very much.
In the next episode, U Lethbridge history professor Dr. Sheila McManus explores why borders are stupid.